Committee and the Center for Bioethics and Humanities in Aurora, Colorado. I'm Julie Swaney. I'm the co-chair of the Ethics Committee, and I'll be moderating today. Ethics Grand Rounds, which many of you know, is held monthly on different topics of ethical inquiry. And today we're really fortunate to hear from Dr. Mark Earnest on health policy. Thanks for muting during the presentation. And please enter your questions in the chat so that we will have an opportunity to address those at the end. So I want to introduce Dr. Earnest. He is a tenured professor of medicine at University of Colorado Anschutz Medical Campus and the division head of the Division of General Internal Medicine. He served as the founding director of the Interprofessional Education IPE course for University of Colorado Anschutz Medical Campus and co-founded and co-directed the LEADS program, which focuses on leadership, education, advocacy, development, and scholarship. So this is a program to train health professionals in leadership and advocacy skills to improve health of the underserved. Dr. Earnest earned his medical degree at Vanderbilt and a PhD in health and behavioral sciences from the University of Colorado. For civic, educational, and community accomplishment, respectively, the University of Colorado has awarded Dr. Earnest the Thomas Jefferson Award, the President's Teaching Scholar Award, and the Joseph Sewell Award. Dr. Earnest was a physician advocacy fellow with the Open Society Institute. His advocacy work has included media and legislative strategies and is focused on expanding access to care for Colorado families, reducing conflicts of interest among providers, and promoting prevention through policy. So it is really with great honor that I introduce Dr. Earnest, and we'll let him take this away as he talks about the, at times, daunting topic of health policy and where we are and perhaps what's next. So thank you, Dr. Earnest.
Thank you, Julie. Let me try to share my screen. Is that visible now? Is my PowerPoint
good?
Yes.
Okay. So I was just reflecting, I think the last time I did this was January of 2017, and I don't know if you just catch me at the right time in the summer and I'm not really thinking about what's coming, but it was a daunting moment then to try to make sense of health policy, and a challenging moment now. And I'll do my best. I have one disclosure. I do serve on an external advisory board for a workforce development, professional development center that's part of United Health Group. As I noted, I'm going to be doing my best to read some tea leaves and to talk about some things that may be a little uncomfortable for us to talk about. But and I just want to recognize that this is a very uncertain time politically and in terms of health policy. So I want to try to sort of make some sense of what may be in front of us and some of the things we may need to navigate in the months and years ahead. So I do have just 3 learning objectives that you probably saw in the invitation. Describe the possible paths to universal healthcare coverage, to discuss the current political environment and how it may constrain or enable healthcare reform, and then to discuss some of the elements of our own culture and history that have prevented us from getting to universal healthcare to this point in our history. In my department, the Department of Medicine, it's tradition for us to start with a case presentation. So I would like to do that. In the interest of confidentiality, I'm going to just use initials. Our patient is non-binary, but since birth has been referred to by feminine pronouns. So I'll use she and her to describe the patient. And this patient was brought to us by the responsible adults, by her guardians that care for her for failure to thrive. Signs and symptoms include longstanding narcissism and some delusional thinking, but increasingly erratic behavior, which is at times high risk and violent. One diagnosis that has been proposed is dissociative identity disorder, which many of you all may know as a split personality. These are some things, I'm an internist, so I'm not an expert on dissociative identity disorder, but some of the characteristics, it's usually a reaction to trauma as a way of avoiding bad memories. Characterized by the presence of two or more distinctive personality identities. Each of those may have a unique name, a unique personal history, unique characteristics. The only treatment for dissociative identity disorder is talk therapy. A few other characteristics, behaviorally, it's manifested by impulsivity, self-destructive behavior, self-harm. Mood, there's often a prevalent feeling of anxiety, feelings of detachment from self or mood swings. Psychologically, an altered consciousness, depression or flashback. Also common amnesia or blackout. I will share some demographics that our patient is a 245-year-old developmentally delayed nation, which you all may recognize and may have anticipated from my description. And I say developmentally delayed, we're continually described as a developed nation, and that's usually in reference to where we are economically and in terms of our manufacturing capabilities, but that in terms of sociocultural aspects and in terms of how we view health and healthcare in this country, I'm going to make the argument that we're in fact developmentally delayed compared to peer nations that we compare ourselves to. So my title said, what's new in healthcare? I want to start with just the things that aren't new, which are probably familiar to most of you all. This STEM, we are the only developed nation. You all can probably complete that sentence. We're the only developed nation that doesn't provide a basic level of healthcare to everyone. We actually spend twice what our peer nations do, and yet still don't deliver care universally. We have shocking disparities in healthcare and healthcare outcomes and health outcomes in our country. So there are counties in our country where mortality rates for mothers and for neonates look very similar to parts of sub-Saharan Africa and rural parts of South America. And of course, our discussion about healthcare is highly polarized. These things, none of these are new. And I gave my first Grand Rounds presentation on healthcare reform in 1995. These things were all true then, and they remain true now. Well, what is new? And one of the things that I think will really color healthcare policy in the months and years ahead is the new configuration of the Supreme Court. So as I'm sure most everyone on this call is aware, the three new conservative justices were appointed under the Trump administration. And there is a raft of healthcare policy decisions that have been heard or are going to be heard and for which there'll be rulings on in the next 12 months that could certainly affect healthcare. I'm just going to go through a few of those. One is the Affordable Care Act, or Obamacare. And if you'll remember, this was passed under budget reconciliation. So budget reconciliation is a procedural process by which things can pass the Senate with a simple majority. And the requirement for something to pass under budget reconciliation is that it must be about the budget, or it must be based on, it must have a tax implication. So the ACA was able to pass because it had a tax implication under the individual mandate. As you all probably know, that this was overturned in a previous session of Congress. And there's been an argument since there's no longer a tax implication for this, that it was illegitimately passed under budget reconciliation and therefore unconstitutional. So this is a case that has been heard, and there remains a possibility that the Supreme Court could actually strike down the ACA and send it back to Congress. there has been an issue around Medicaid work requirements. So several states, probably most famously Arkansas, have said, it basically created laws that said for you to have Medicaid benefits, you either have to prove that you cannot work or that you're currently working. I raise Arkansas as an example because it's one of the ones that's been most thoroughly looked at. The conclusion is these actually have resulted in higher expenses for Medicaid and have reduced the number of people who are covered under Medicaid. And it boils down to a states' right question. So do states have the ability to do this, or is there a presumption of benefit for those who are eligible for Medicaid, and they should be able to presume that they are eligible for it? This will be decided by the Supreme Court as well. You all are probably all familiar with Roe v. Wade and some of the cases that are heading to the Supreme Court, which would impact access to certain reproductive care, specifically abortion. There has also been a challenge to the ACA. You may be aware that contraception was a required benefit under the ACA. A number of employers, predominantly faith-based employers, have raised what has been called the conscience rule, which would exempt them from covering contraception based on a religious exception. And then actually there's several public health measures that are being challenged. So one is under the aegis of religious liberty, do public health officials have the ability in a pandemic emergency to close down places of worship and or regulate places of worship in the interest of infection control? Economic liberty, so do they have the right to do the same thing for businesses? And then a principle called non-delegation, which public health authorities operate on delegated authority. And there's been a challenge that would say legislatures do not have the right to delegate authority to public health officials. So all of these are things that will be decided by the Supreme Court in the coming months. I mentioned earlier that I'm going to bring up some things that may be a little uncomfortable. And so I want to make a warning here that it seems like we can't talk about a sunrise these days without lapsing into politics and partisanship. And certainly we can't talk about healthcare without talking about the political parties and about the politics. I want to try to take an approach to this that is as evidence-based and objective as possible, but we all have our affiliations with parties, and often those are things that hit the side of our brain that is they can be challenging to talk about. So I want to just list a few things that I think that are based in fact, that of the two political parties, dominant political parties right now, really only one of them in the last 30 years has advanced any legislation to expand access to care or had in their platforms the goal of universal care. The last Republican administration that espoused universal care and had a policy proposal to advance that was actually the Nixon administration, which had proposed a employer mandate that employers would have to cover employees. And the last really conservative proposal for universal health care was one that came out of the Heritage Foundation, was adopted by Massachusetts under Governor Romney before a couple of years before he ran against it as president. So there is a really distinct difference in the way the political parties have addressed healthcare policy and where their current policy platforms are. I'm just naming that, and we'll discuss that a little bit further. So really, how would we get to universal coverage? The thing about universal coverage is the policy is not difficult, it's the politics that are. So there are really only three basic formulas. One is a universal public insurance model. So that would be in US parlance, Medicare for all. It would be a system that would look much like Canada's, where you have one public financing mechanism that everybody is under. The second would be a universal public health system, which is much like Britain, where the government owns the hospitals and the clinics, employs the providers. This is, of course, like our VA system. And then the third would be a mandated form of insurance that is in fact a public-private partnership, and that insurance would be fairly heavily regulated in terms of how insurance companies operate. This is much like the Swiss model. And you may recognize elements of this, that we made an effort to get to universal coverage through what became Obamacare. It was an expansion of public insurance through Medicaid to cover the low-income Americans, and then a mandated, regulated private insurance model. You may be also aware that the mandate was stricken out, which is why it's now being challenged in terms of its constitutionality. So we had an election, and Joe Biden was elected. So I want to just review with you the Biden plan that he ran under. So this is candidate Biden. Stated goal, he didn't use the term universal, but that every American would have access to affordable health care. He would do that through a public option. So this would be a form of public insurance that would be available on exchanges and would compete with private plans, to increase tax credits to lower premium costs. So you may be aware, under Obamacare, the tax credits taper off and actually stop at incomes of $400,000 a year. Biden's proposal was to eliminate the $400,000 tax cap, for eligibility for the tax credits, and basically to say that no family should spend more than 8.5% of their income on health insurance premiums. And the other change they made is the prior tax credits were indexed to the silver plan. So there are 3 tiers of Obamacare plans: bronze, silver, and gold. Biden would increase this so it was indexed to the cost of a gold plan. He would expand coverage to 4.9 million low-income Americans, either through encouraging their states to expand their Medicaid programs as allowed for under Obamacare, or in those states that wouldn't take those steps, offering the public option to those individuals at no cost. There are a number of different regulations aimed to reduce drug prices. And interestingly, no mention of the individual mandate. A couple of things about that: you don't get to universal without a mandate because people can opt out. The second thing I would note is that the individual mandate, if you look at polling that occurred around Obamacare, while Obamacare at times had very low public approval ratings, if you took out the individual elements, every single one of those consistently polled above 50% throughout the history of Obamacare, except for the individual mandate, which was the piece of it that was by far the least popular among the public. Of course, the election didn't play out with quite the mandate that Biden might have hoped for. He is going to govern with a much narrower majority in the House than he might have hoped for, a really razor-thin Senate majority that's really going to be determined by Vice President Harris's tie-breaking vote, and still a headwind of Republican opposition, both to Obamacare and to many of the policies that he has proposed. What I expect we'll see in terms of paths forward for President Biden and for the Democrats, if they want to advance this agenda, we've already seen a large number of executive orders. In the face of congressional paralysis, which we've actually had over the last several administrations, we've seen much more in terms of executive orders because of the difficulties of getting things through the Senate. We'll also see, I think, a lot more creativity from the Center for Medicare and Medicaid Services in terms of changes in regulations, the waivers they authorize, and various demonstration projects that they may encourage to increase access, lower costs, and change the way in which care is provided. The budget reconciliation, which I mentioned earlier, Senator Bernie Sanders is now chair of the Budget Committee and has already signaled that he intends to aggressively use budget reconciliation as a way of getting policy priorities through the Senate with a simple majority vote. And of course, there's been a lot of discussion about ending the filibuster as a way of breaking the logjam in the Senate. I will talk just for a second about what has, been the health policy position on the Republican side. Largely, it's been reactive to what the Democrats have done over the last several Congresses. The rallying cry has been repeal and replace. There has been nothing proposed to replace, and as I mentioned, the last effort for repeal, or presumably the last effort for repeal, is pending before the Supreme Court. There is not a concrete set of proposals to discuss, and that most of what, if you listen to Republican leaders, most of what they propose are market-based solutions, which are things like allowing insurance to be sold across state lines so that you would eliminate state-level regulations. The concern about that is the fact that those are consumer protections, and whether that would institute a race to the bottom. But again, no specific proposals to expand access to care or to move towards universal coverage. So my read really on what we can expect in at least the next 2 years under the current Congress, we may see some tweaks in Obamacare. We may see some states that individually will make the move to expand Medicaid who have not done so already. We may see some regulations that will pass to lower drug costs. And I would note that there is actually bipartisan agreement on a number of those. And I think that that's one of the places where we may see a bright spot and some collaboration. We may also see some state level innovations. States have struggled to achieve universal coverage because of how much of the financing is at the federal level, and how limited they are in terms of being able to manage the budget lift that's required to do this at a state level. But Colorado, over the next month or two, you'll hear a fair amount about a public option that Colorado is considering that's starting to take shape. So I think for major changes to happen, we are going to have to wait for politics to change before we'll see a lot of movement. So I want to spend a little bit of time talking about us as a nation, and about why we find ourselves here, and why healthcare is viewed in the light it is, and why we've struggled so much to accomplish what other countries in the world have done. And I would start with this question: why are we so different? And propose that one of the ways we are different is that we have historically had a very high level for tolerance for inequity within our society. And certainly healthcare is one of the lenses in which we might see that in its sharpest relief. I want to show you some comparison slides. And the first is really to challenge an assumption that I think is prevalent in the US, but perhaps more broadly, which is that income is highly correlated with health outcomes. And that in fact, if you compare wealthy nations, our peer nations, there is no correlation between average income in those societies and health outcomes. And so this is just looking at life expectancy versus national income per capita. And you can see it's just a sort of a random scatter plot, no relationship at all. And I can tell you, if you use other markers of health other than income, you'll see a very similar distribution, that average or nationally average per capita income actually does very poorly predicts health outcomes. That's not true for very poor nations, and there does appear to be a threshold effect for developing countries. But for developed countries, this is what you see. What you do see is that, in fact, measures of equity, so the distance between the rich and the poor in a society, highly correlate with health outcomes. So what you see here on the y-axis is an index of health and social problems. you'll see over here in the box a list of all of these different health and social problems, and they've developed a single measure out of this. But this works for any of these you want to look at. And then across the bottom is a measure called the Genie Index, which looks at the distribution of income within a society and the distance between the rich and the poor. And you can see a very tight correlation between the level of income inequality in a country and these health outcomes. This is basically the same graph, but looking at the states, at the 50 US states, based on income inequality across those states. You can see the correlation is not quite as tight, but still holds. Again, it's not just, if you peel these social problems out or look at individual health outcomes, this relationship holds across almost all of them. And if you're interested in learning more about this, I'd point you to this book, The Spirit Level, by Wilkinson and Pickett, that came out in 2009. They also have a website, the Equality Trust, and a lot of this data is available there if you want to find out more. They have pages and pages of data looking at these sorts of correlations. If you want to look at just how we compare, how much that inequality looks like, this is a graph that compares the ratio of wealth between the richest 20% and the poorest 20%. So again, 20%, we're not talking about the top 1% or bottom 1%, but 20%. So pretty broad shoulders. And you can see in the United States, the rich are almost 9 times richer. The richest 20% are almost 9 times richer than the poorest 20%. And you can see how our peer nations compare. It has not always been this pronounced, and this is a complicated slide, so let me walk you through it. It was published by the New York Times a few years ago. But what you see is on the y-axis, year-over-year income growth. So from 1% to 6%. And then what you see across the x-axis is percentile of income. So it starts at the 5th percentile. So this is the poorest 5% of Americans. And then what it shows is 2 different years. So 1980, the year Ronald Reagan was elected. And this is the curve. So the poorest, the 5th percentile actually had the highest rate of income growth at about 3.5%. The richest, 1% actually had the lowest rate of income growth at just about 1.5%. 34 years later, you see the curve you see in orange, and that in fact what has happened is the poorest, the 5th percentile actually has seen no year-over-year growth in income, whereas the top 1,000th of 1% is actually now growing at a rate of about 6%. And that this has happened in a fairly short period of time. So 34 years that we've seen this sort of inversion in the rate at which inequality is growing in our society. One thing I would point out that in 2014, the consumer price index was 1.4%. And what that means is that everybody below the 90th percentile is actually losing ground economically relative to the economy. So I bring this up just to raise the issue of inequality and what its impact is. That political scientists, history will tell us that democracies require a level of equity to remain stable, and that when we get unequal and when our inequality grows, that there is there's a consequence to that, and there's an instability to democracy that happens. And I think we're experiencing such a time right now. And the case I want to make is that healthcare is very much embroiled in this battle. So to sort of summarize where we are, these are very real problems that are affecting more and more people, that a growing percent of our population is losing ground economically. They have less security, they feel less secure, they have less economic opportunity, and that what they are experiencing and perceive is a very unresponsive political system. And I want to focus for a second on that the feeling that Americans have, and I think this is true probably regardless of your political orientation, that our political system is not currently solving the problems that are in front of us. and that there is a growing sense of frustration around that reality. And I'm going to show you a slide here that illustrates that. And this actually is what's referred to as the filibuster rule. It's actually also referred to as a cloture vote. So, you know, what we see in what is called a filibuster is not what we think of as Mr. Smith goes to Washington and talks for 24 hours. But in fact, it's the votes that you have to have 60 votes to close debate and then bring a measure to a vote of the Senate. And you can this rule, I mean, it's not in our Constitution. It's a Senate rule. Was established in 1917 during the Wilson administration, at a time where they were struggling to pass laws relative to our participation in World War I. And it was viewed as a national security thing. And you can see it was very rarely used, and became more commonly used during the 60s as a means for the conservative Democrats to hold up civil rights legislation. But what you can see is that really over the last 20, 30 years, we've had a dramatic increase in this, and it's gotten to the point where almost nothing can get through the Senate. So we have a Congress that's has been very unresponsive to solving the problems, and has mostly been embroiled in seeing who can get the majority in the next election. So I do want to note that these are real trends, and that there are a lot of people hurting, and that it's not difficult to imagine people looking back and seeing a world or a country that we view as being better in the past, and to be fearful about what's coming in the future. But I do want to talk a bit about what the political implications of this. So what you see here is the Oxford English Dictionary's definition of populism, which I think describes our moment quite well. A political approach that strives to appeal to ordinary people who feel that their concerns are disregarded by established elite groups. So I've just described an unresponsive Congress, and I've just described the way ordinary people are feeling at the moment, and the evidence we have that people are not well served by the status quo. And I'm going to propose that we really have two brands of populism that are part of our discourse right now. One is an economic populism that would basically sum our problems up this way. It's an unequal distribution of resources and opportunity. The elites that are the source of the problem are might be called Wall Street in short, but basically, the rich and powerful, and that this arrangement has in fact corrupted our government. The other view is a cultural populism that would define our problem as an erosion of our values and institutions, and a dilution of fundamentally what it is to be American, that our American identity is at risk. The elites in that formulation are actually cultural liberals, in some cases academics like us, and that this has in fact corrupted our government. And I would contend that both of these were on the ballot in 2016. So Bernie Sanders may in fact be the best representation of economic populism, who really ran very much against Wall Street and as a very much a sort of pro-labor, single payer healthcare kind of guy. And then Donald Trump famously came down the elevator in New York talking about the murderers and rapists coming over our borders, and the threat from, the threat of American identity. And that's been a theme throughout his presidency. If you try to dissect Hillary Clinton's message, I think there clearly were lots of themes of economic populism, and yet they were voiced by someone who was paid frequently hundreds of thousands of dollars to give speeches to Wall Street investment banks, and I think was viewed as not being credible. There has been if you look at the polling, there is some suggestion. In fact, Bernie Sanders, had he been running against Donald Trump, might have actually garnered a larger share of the vote than Senator Clinton did. then I want to just raise another question I'm going to, or theme that I think is an interesting thing to explore, which has been the marriage in conservative politics of business interests and cultural populism. And I recognize I'm lumping a lot of things into that, but let me try to define what I'm saying. That the business interest is basically the conservative small government approach. What the Chamber of Commerce wants is less government regulation and less taxation. And it doesn't really care that much about whether creationism is taught in public schools, or what abortion rights look like, or whether gay people can marry, but that there has been a marriage of convenience, a political marriage between those two, where the two have actually both benefited in terms of their policy goals and their political goals by combining those interests. I would say that business historically has been fairly hostile to healthcare reform because of the burden they bear. So businesses that pay those costs are eager to not see them go up, are concerned about the taxes that may be levied on them if we move towards a governmental model of insurance. And then in businesses that do not pay costs of health insurance are not eager to take those on. And so historically, that's been true. Whereas I think the cultural populists have looked at healthcare from a different lens that I want to explore a bit, but that these two have coalesced really to form the conservative wing of our current politics. And that's something that's held together really for probably close to 40 years now. I'm going to talk a little bit about this book by Kurt Anderson and his formulation of this, but he makes the point that marriage was actually somewhat intentional and tells the sort of following narrative, that if you look over the span of the last 100, 120 years, we had a time of really dramatic inequality with the Gilded Age, which has a lot of parallels to what we're living through right now. Number of things happened, but we came out of the Depression with something of a national consensus, which is that the government can solve problems, and that government is a necessary function. And really from the 1930s up until the 1980s, we had a very high degree of trust in government and among the public. Beginning in the 60s, we had the rise really of modern conservatism. Barry Goldwater was really the first national political figure to voice some of these ideas. Ayn Rand was a popular figure. Her philosophical, her philosophy of objectivism, manifested so well in the novels that she wrote, which really, if you've read them, paint a really stark picture of a small number of creative elite capitalists who really are sort of the pure and noble humans, and government and commoners as more sort of clinging and parasitic, and really a stark picture of meritocracy. And then Milton Friedman, who was a University of Chicago economist, who very much was put an academic flavor on supply side economics, and who famously said that corporations should take no social responsibility beyond making as much money for their shareholders as possible. These were fringe ideas in the 60s, but they became ascendant in the years that come. And what Anderson documents in this book is actually a meeting of a small group of very wealthy, powerful people who really laid out a strategic plan to develop think tanks, to develop economic conservative academics, and then to start investing in political leadership that would push forward these ideas. Their dream came true when they had a telegenic former actor in Ronald Reagan, who was really able to articulate these ideas in a very compelling way. and so compelling, in fact, that when Clinton was elected, he actually adopted so many of them and continued the regime of deregulation and tax reform, which was increasingly regressive. All of this under the guise of meritocracy. So in the part of meritocracy I think we would all agree with is that hard work and talent should be rewarded, and that's certainly something that's been part of the American experience, or at least what we've been proudest of about our country over time. The problematic challenge with a meritocracy is that if you believe strongly in a meritocracy, then that becomes the reason people don't thrive is the fact that they, by default would be deemed as unworthy, not hardworking, et cetera, and that it's in fact their individual fault that they're not thriving. And as I showed you in those earlier slides, that more and more Americans are not measuring up if we use meritocracy as our yardstick, that more and more Americans are falling behind and are anxious about their futures, and that this notion actually has become increasingly problematic. So I show here that raise the question of what is the meaning of healthcare? And on the left side is sort of a meritocratic set of understandings that healthcare is about personal responsibility. If you take responsibility, you will have coverage and you will be healthy, and that it also is it's a good or service that's exchanged in the marketplace through free enterprise. And on the right side is a different understanding that it's about the common good. It's a shared social commitment. It's part of what we owe each other. And then I would assert that most developed countries, all of these elements are present. That you would find a hard time finding people who would make an argument to say there's not some personal responsibility for health or healthcare, and also that there's not some elements of free enterprise, but that they in fact are balanced. And yet historically in the United States, we have the meritocratic argument for healthcare has been enough to prevent us from moving forward to balance those and to have universal care in the way that other nations have. I want to talk through just a couple of books that I've read recently and some ideas I wanted to share, which I think may shed a little bit of light on that. One of them is this, Dying of Whiteness, by a guy named Jonathan Metzl, and he is a sociologist and a psychiatrist at Vanderbilt. He actually, I think, is on the docket to talk to this group in May, but he's written this book called Dying of Whiteness, and he has done exhaustive field work in 3 southern states predominantly. And this is the description in the introduction of the book. It's a narrative about how whiteness becomes a formation worth living and dying for, and how in myriad ways and on multiple levels, white Americans bet their lives on particular sets of meanings associated with whiteness, even in the face of clear threats to mortality or to common sense. And in the book, he describes a conversation he has. It's actually a focus group with a group of white men, all of whom have serious medical illness, all of whom have no health insurance, all of whom have not signed up for Obamacare expansions that they're eligible for. And this is a quote from one of them. So, even on death's doorstep, Trevor wasn't angry. In fact, he staunchly supported the stance promoted by his elective officials. Ain't no way I would ever support Obamacare or sign up for it, he told me. I would rather die. When I asked him why he felt this way, even as he faced severe illness, he explained, we don't need any more government in our lives. And in any case, no way I want my tax dollars paying for Mexicans or welfare queens. So, here are the themes. He's actually views it as his responsibility to not to take this government program, that the government is his enemy, that the government is the problem, and that in fact the other part of this is that people that these policies help are not people like him, that it's an other, it's somebody who is undeserving of this, and it's his responsibility to make sure they don't get it. I want to call your attention to another book, and if you read one book this year, I'd recommend it be this one, Caste by Isabella Wilkerson. And she speaks a bit of this issue of whiteness, and says this: slavery was not merely an unfortunate thing that happened to Black people. It was an American innovation, an American institution created by and for the benefit of elites of the dominant class and enforced by poorer members of the dominant caste who tied their lot to the caste system rather than to their consciousness or their consciences. So sort of saying the same thing as Metzel. And she said this about our last 4 years. So that summer and into the fall and in the ensuing years to come, amid talks of Muslim bans, nasty women, border walls, and shithole nations, it was common to hear in certain circles the disbelieving cries, "This is not America," or "I don't recognize my country," or "This is not who we are," except that this was and is who our country was and is our country, and this was and is who we are, whether we have known or recognized it or not. One other quote from the book I want to share, which is from an interview she did with Taylor Branch, who is Martin Luther King's biographer. And I thought this was particularly chilling after January 6th. So the real question would be, if people were given the choice between democracy and whiteness, how many would choose whiteness? And then one final point she makes in the book is that there are in fact historically 3 human systems of castes. The first is probably one everybody's familiar with, India, which is thousands of years old, very well established system that despite legal efforts to remove it remains very much culturally in place now. The second is the United States and the caste system we created to create a moral framework to allow us to sustain slavery. But the third actually was Nazi Germany, and that Nazi Germany set out to intentionally create a caste to basically dehumanize and delegitimize a group of people. And that as they went through the process to do that, they looked for legal examples of how countries had created legal systems to do that. And the example they found was in the United States. In eugenics laws and in a variety of laws that actually excluded African Americans from full citizenship, even as late as the 1930s. And one of the quotes that she shared, so these ultimately ended up in the Nuremberg laws, which were the ways that the Nazis legally excluded Jews. But noted this, that Hitler especially marveled at the American knack for maintaining an air of robust innocence in the wake of mass death. And ironically, they found a number of laws when they looked in the United States that they felt went too far, that they didn't feel they could get away with. And of course, part of our own mythology is our the heroism that we displayed in going and correcting this great wrong. And yet the irony is that we return to our own country largely blind to the system that informed the creation of that system, and the decades we've spent since then still trying to dismantle our own caste system in this country. And of course, as I noted, that inequality comes as cost, even those at the very top of the system, that if you compare the wealthiest people and the health status of the wealthiest in equal countries versus unequal countries, there is a cost to be paid for everybody from this inequality. And I thought Booker T. Washington said it best: you can't hold a man down without staying down with him. Which brings us back to healthcare. So the point I want to make is that part of our challenge is that we have, is that healthcare is wrapped up in these systems of oppression, these systems of inequality that are deeply ingrained. But I believe that optimism is an evidence-based response. And so I do see glimmers of hope that I want to share. And I'm not quite sure what to make of this slide, but Gallup every year has done the same poll to say, what is the most urgent problem facing the US in healthcare, the most urgent health problem? And you see the blue box there. So, and if I could extend it down, you would see a trend where cost and access were over the last 20 years have gradually risen. But notice what happened this year, that 69% of Americans have figured out what seems to be obvious, that flu and viruses are a pretty big problem. But it's pretty rare that 69% of Americans agree on everything. And when we get on the other side of this pandemic, my hope is that we will see healthcare in a different light, and that perhaps we'll see each other in a different light as well. And that some of that cohesion may come back to the system we have and the flaws that have been exposed by the pandemic. The second thing I wanted to show you is these trends also tracked by Gallup over a number of years that just ask, is it the government's responsibility to make sure all Americans have healthcare coverage, or is it not? And you can see that in 2007 was the point where the highest percent of Americans said, yes, it is the government's responsibility. A year later, President Obama was elected, and you can see it start to plummet. And this was around the time where we were having an active debate about healthcare, and where the Republican Party really lined up completely in opposition to the reforms that were being discussed. And as I would note, these were actually reforms that were developed by the Heritage Foundation and had been championed. Their first champions were actually Republican leaders. That campaign was so effective that you see the steady erosion to where only from 69% agreeing with that down to a low of 42% in 2014. Now, I would note that Obamacare passed in 2010, but it was not implemented until 2014. And that was and that was, I think, politically challenging in that there was a lot of time to really demonize the law before people actually experienced the benefits of it. But you can see from that nadir in 2014 till now a growing sense that this is the government's responsibility. And I would note that this isn't about big government or small government. It's simply reality that we will never get to universal coverage without governmental intervention and without the government taking responsibility for creating a system that will provide it. So a steady upward trend that we've seen since that time. I do, 2020 is what we in medicine use to refer to as perfect vision. My hope is that 2020 will come to mean that. I certainly think it will be a hinge in history where we will view things before and after the pandemic, and that we will be forever changed. Again, my hope is that we will, that this will provide a lens through which we see healthcare in a more productive light and a way that we can move forward. I want to come back to just talking about where we started, so our split personality. And I would propose that we have really a tug of war between two identities right now. Are we a multicultural melting pot, or are we the white Christian patriarchy that we have historically been? And that whether people, that these are not necessarily ideas that people embrace outwardly. Some do, but that there's a level of kind of cultural comfort with the way things have been, and that there's a certain amount of anxiety that comes with the fact that these things are changing. And demographically, we know that we will not be majority white, we will not be majority Christian, and that in so many ways, the traditions of patriarchy are all things of the past, and that those are challenging changes to live through. But Ron Brownstein stated it this way: how long can Paducah tell Seattle what to do? And that much of the struggle right now politically is really an effort to maintain minority rule. Much of what we're seeing with challenges to electoral processes, and that in fact this is not sustainable over time. And then in fact, we have to move towards a multicultural society and making sense of that. This has been our founding challenge, that we are fortunate to have some amazing founding documents, and that the first word in the Declaration of Independence is one that I think we've struggled with, which is, who is we, and how do we define that? And we know that the phrase "all men are created equal" was not even literally true at the time. That it did literally refer to men, and it did not literally refer to all of them. And yet we have made progress over this time as we've expanded our idea of who we is, pardon the grammar of that, and who we include in that pronoun. So what is the path forward? I think, and our challenge today, I do think we have a challenge to restore faith in government. We're in the midst of a crisis, and I think it's very important that the government go about the business of solving it, and that current leadership come together to figure that out. We are learning to talk about equity and to see equity in new ways, and I'm encouraged by that. I think I would like to see that grow, and I think you're gonna see much more of that in terms of defining policy goals in terms of equity. As I mentioned, we need to have trust in our electoral system, and that's part of restoring faith in government. We clearly have a problem with the fact that we talk and live in two different worlds. And I think there'll be some challenges in terms of how do we start to soften those echo chambers. And you're starting to see that now, both in terms of FCC regulations, but also in terms of self-regulation of the large social media companies, as well as the fact that the business community, I think, is recognizing the challenges of some of the things that it has gone along with. So we're starting to see some businesses challenging some of those structures. I do think it's important for us all to be ready to listen to one another and to recognize that a lot of people are in pain, and we need to be ready to respond to that. And that both means being empathetic, but I think it also means being willing to call out behaviors that need to be called out, and trying to extinguish those. And I've said this before, I think those of us in healthcare really bear a disproportionate burden to talk about the realities that we see, and to speak to the mistruths that are frequently spoken. There are a lot of misperceptions about healthcare, about what it means, about its importance, about how it functions, and that in fact we're the ones that see the inside. And I think it's very important for our voices to be heard, both in the public square but in our own social circles. And I'll end with this. It's a quote from Cast, speaking to those last couple of examples. Radical empathy, on the other hand, means putting in the work to educate oneself and to listen with a humble heart, to understand another's experience from their perspective, not as we imagine we would feel. Radical empathy is not about you and what you think you would do in a situation you have never been in and perhaps never will. It is the kindred connection from a place of deep knowing that opens your spirit to the pain of another as they perceive it. So I'll end with that, and I'm glad to entertain any questions.
Okay, Mark, thank you so much. You are reminding me of a quote from Mark Twain, which is, history doesn't repeat itself, but it rhymes. And I think there is a lot that you have talked about in terms of themes, dynamics, culture, and for better and worse, that has rhymed throughout our history. And we're at a particular juncture. And thank you for addressing our 245-year-old patient in terms of whether she is doomed to remain split, or actually there is some hope for pulling together both equity and inequity in healthcare. Have a question about the ACA. Does the centrality of tax credits to the functioning of the ACA put the whole act into legitimacy as part of budget reconciliation?
Yeah, I'm not enough of the legal scholar to parse the legal arguments about that. And there may be others. I've read most of the arguments I've read would say that would predict that a conservative majority on the Supreme Court would still would not invalidate the law based on basically what's a technicality. And if it did, if it was sent back to Congress, the question would be, how does Congress respond? And, could you go back through budget reconciliation and put the individual mandate back in? So I actually, I don't feel qualified to predict with great accuracy what will happen, but that's the question that the Supreme Court's going to decide.
Wonderful. There are a number of people, quite a few, who are also very appreciative of all of the book recommendations, and quite a few who have been very influenced by CAST and feeling that that's a must read for people. One person is asking, how do you actualize radical empathy?
Yeah, so in the book, she tells this one very personal anecdote of a plumber who comes to her house, opens the door and sees her as an African-American woman, and the immediate sort of response that is, and then the conversation they have that turns personal, and the thawing that happens. And so she describes radical empathy as a commitment that we all need to make as individuals to how we engage people who are different than us, and our commitment to understanding them. And I think that for us to be a multicultural melting pot and a functional democracy, we really have to learn to listen and to talk across the ways we see ourselves as different. And so she does not propose that as a policy, other than as a personal policy, an individual policy.
Thank you. I think we have time for one more question, though we're at time, and that is, many bills are being pushed to restrict healthcare for transgendered people. Will that make it to SCOTUS in the near future? Do you know?
Boy, I don't know in terms of, I think that would wrap up in some of the, kind of the religious liberty sort of clause that employers, and again, this is, one of the challenges we have if we have an employer-based insurance system, is that employers can object to certain parts of healthcare. So I can see where that would be challenged. I'm not aware of a case that is carrying that towards the Supreme Court right now.
Okay, thank you. I wanted to, in closing, mention that Jonathan Metzl will talk on Monday, May 3rd at noon. So you will be getting an announcement about that, but you may want to tune in. I really thank you, Mark, for your presentation. Very compelling and stirring, and that's clear in the chat as well. Many people stirred, as it should be, around this kind of topic. So thank you very, very much for presenting. We appreciate it.
Thanks for having me.